Hello, my name is Simon Adam. I'm a registered nurse and a nurse educator. I work in the emergency department of a large teaching hospital. I also teach in the undergraduate nursing program in Toronto. I am also a speaker member of Healthcare Professionals Against Electroshock. Electroconvulsive therapy, or ECT, is a psychiatric, quote, treatment, unquote, in which seizures are electrically induced in anesthetized patients for therapeutic effect. Its mode of action is unclear. ECT is most often recommended as a treatment for severe depression that has not responded to other treatment. It is also used in the treatment of people who have been labeled as manic or catatonic. It was first introduced in 1938 by Italian neuropsychiatrists Ugo Carletti and Lucio Bini, and gained widespread use as a form of psychiatric treatment in the 1940s and in the 1950s. Proponents of ECT claim that the treatment is safe and effective, that its negative effects are temporary, and suggest that memory loss is minor and transient. However, the research that attempts to prove that ECT is safe and effective has no indicators of success. It minimizes memory loss when many good studies show otherwise. Edward Shorter's book, The History of Psychiatry, is an example of such bad scholarship. Colin Ross studied the literature on ECT's effectiveness and concluded that ECT is neither safe nor effective. When one finds out about the real lives of ECT survivors, an even more horrific image appears. I introduce Dr. Bonnie Burstow. Dr. Burstow is a long-time researcher into electroshock and a founding member of Healthcare Professionals Against Electroshock. Bonnie.
It was a weekday morning, not unlike the ones that came before, not unlike the ones that were to follow. Bring, bring, went the alarm. Time to get up, urged Earl, reaching over and turning it off. I rose, quickly closed the child's gate, praying that Earl had not noticed. I rustled up breakfast, saw Earl hovering over me. Gotten you, had I left a burner on? Darling, don't forget to mail the letters, he calls out minutes later. Then with a hurried peck on my cheek, he rushed out the front door. Dreading the inevitable, I put off the chore a good hour. Then I gritted my teeth, lifted up Ruthie, and started scouring the streets in search of the mailbox. Where could it have gone? It was here yesterday. At long last, I passed a little green house, a white picket fence at front. Shortly thereafter, I happened upon a rectangular box. I dropped the letters into what appeared to be a slot. Fine and good, but how does one get home? I whirled about, intent on retracing my steps. Here was the little green house with the white picket fence on the right. I passed it, scrupulously turned whenever the street turned. Our house was nowhere to be found. Yet again and again, up would pop the little green house. Lost. Lost. Sir, I call out to an older man in Bermuda shorts ambling by, could you give me directions to 532? No 532 here. You must be looking for Palmerston Avenue. This is Palmerston Square. So there's two Palmerstons? 3, he corrects, chuckling. Then a curious look comes over him. Excuse me, but aren't you the young lady who asked me this yesterday, he queries, eyeing me ever more keenly. If this is a joke, young lady, it's not funny. I apologize, back away mortified, eventually find my way home, with Ruthie hollering that she is hungry again and the word vacuum mysteriously coming to mind. I pull out what appears to be a Hoover. Then suddenly, I remember. Groceries, God help me. I'm supposed to buy groceries. Also, my daughter is hungry. I instantly stashed the vacuum in the hall closet, hoping that's where it came from, then feed Ruthie. Then once again, the two of us set out into the wilderness that is Toronto. And once again, I search and search. A tall, burly man in a police uniform is positioned in the middle of the street directing traffic. Now, somehow, his hand signals, if that's what they are, do not compute. But this time, I know better than to draw attention to myself. I stand at the very edge of the sidewalk, doing absolutely nothing as the policeman gazes my way. Who could get in trouble just by doing nothing? Suddenly, a horn begins honking, then another and another. The policeman stares right at me while waving his hands progressively quicker. And now he approaches, his expression very like Earl's. "Lady, just what are you expecting me to do?" he asks. "Turn green?" Eventually, I catch sight of the local dominions, even usher Ruthie safely through the door. And while I cannot make head or tail of my grocery list, I recall that we are out of peas. As luck will have it, I spot the right row, the right section of the right row. With trepidation, I position myself smack in the middle of the peas section. I reach out my hand, then I stand in front of those hundreds of tins of peas, utterly stymied. So many sizes, so many kinds, Libby's, Aylmer's. How's a person to choose? Beads of perspiration forming on my brow. I take a deep breath, grab a tin at random, then hightail out of there as quickly as my legs will carry me. Now I am halfway out the door when it dawns on me that I have not paid. Also, there is one other item I simply have to pick up. Hoping that security is not on the way, I re-enter, make my way to the wheat counter, then I take another deep breath and brace myself. You see, pig, that turned out to be a staple in the Smith household, and it utterly flummoxed me. Pork chops, ham, sausages, bacon, Newfoundland steak, hell, being Jewish and electroshock to beat, they all seemed the same to me. Now, Earl would answer all my questions, would keep rattling off the different types, but try to hold on to them though I did. Every name, every description would come leaking out of my brain. "So, lady, what's it today?" asked the man in white behind the counter. A few pounds of that," I stammer, pointing at something reddish. Meat in hand, I head over to the cashier, give the woman every ounce of lucre in my possession. Her eyebrows raised, she hands me back my bills, most of my bills anyway, and several coins, together with what must be an itemized receipt. I glance at it, another blur. Then I pick up my daughter because she is clearly tiring and scurry home. "This is just fine," says Earl a few hours later, gobbling up the poor imitation of a dinner. But I can tell from his eyes that all this mishigas is wearing him down. 8:30 p.m. I tuck in Ruthie, hear her scream for her father, then Earl and I sit and sit and sit in that living room. He tells me about his day and I pretend to be following. I tell him about mine and he pretends to be listening. I breathe a sigh of relief, take the pills, observe him watching me. At long last, the moment that I have been waiting for arrives. I get to crawl into bed, that nice, warm, comfortable bed, and call it a day. I bury myself in the safety of the blankets, eager to fade into nothingness, eager to forget. But now Earl, he's crawling on top of me. I instantly spread my legs. Oh, let him come quickly, I pray. Finally, I close my eyes. I drift off, glimpse a better place, a better time. It is our 4th birthday, and attired in our new black tunics, Rose and I are blowing out the candles. Now all 4 candles are out, and the 2 of us are smiling at each other, nestling into the recesses of each other's souls as only we can. "Mazel tov," chimes in my mother's voice. "Never mind with the mazel tov, Ida. Give the girl cakes," pipes up Dad. Even as I savor the first tantalizing mouthful, a shrill sound shatters the stillness, and I awake with a start. Frantic, I cast my eyes about. I spot an alarm clock. I see a bump in the covers next to me. No, no, it can't be. Not here again. And so the days went. How can we possibly keep this up? I wondered. In case anyone is wondering, the shock that Naomi had was not old shock, but new and improved shock. I would now like to introduce two other members of our Speakers Bureau, Terra Dafoe, doctoral student in psychology, and Ambrose Kirby, psychotherapist. Okay, you know, all of us, I think, have had one thing in common, that as professionals who operate in the area of people with problems in living, we have come together to speak out against electroshock, but we all know that other people in our professions overwhelmingly do not. Why do you think that's the case?
As sort of working as a therapist in a hospital setting as well as in the community, I see huge differences in people feeling like they have a voice. And in the hospital where I am, psychology is on really unstable grounds. So this year we've seen a few psychologists just mysteriously disappear. You know, saying like early retirement or, you know, going back to school or things that just, you know, we have a really unsettled sort of feeling around them. You sort of understand that there's something happening behind the scenes that nobody knows about. And so in the hospitals, nobody really knows what psychology does. Psychiatry has all the power. They are the head of every single team. They make all the decisions and everything funnels down through them. But then people wonder, well, then why is psychology here? Mm-hmm. So within psychology, people have a real fear of speaking out because already their jobs are sort of on the edge. Sure. We've seen psychology disappear in hospitals all across North America. So I think that there's a real fear of saying anything that's against the grain, let alone really speaking out against, you know, a treatment, quote unquote, that is sort of psychiatry's, you know, treatment of choice for a lot of things. So I think that, you know, people will lose their jobs. They've lost their jobs for a lot less than we've seen it happen.
Yeah, I think you make a good point, even just in how you describe who we're talking about. We're talking about people with problems in living and how different professions relate and respond to those individuals. And, you know, I think part of the problem of not speaking out against CCT is not understanding the language of it, not understanding the science of it, or the so-called science of it. And the fact of the matter is there is no science that makes sense around ECT. There is no clear proof or demonstration whatsoever that says that ECT even works, as we all know. So what I'm getting at is the language around this so-called treatment really prevents people from feeling confident to speak out against it.
You know, I think before nursing, it's kind of interesting what you say, Terra, about psychology being on unstable grounds and that nobody in the hospital knows that they exist. The time that you worked at the hospital at the same time that I worked at the hospital, and I've been there for 9 years, I didn't even know a psychology department existed. And so that's kind of interesting that so that does hold true. You know, for nurses, you know, the nurses I've had conversations with about ECT, believe it or not, many of them actually don't know it still happens. So they sort of give me this puzzlement that, oh, they still do that? And so that's kind of an interesting reaction, I think, that nurses working at the bedside still don't know certain bedside interventions are going on. So I would wonder what's happening that's, you know, to nursing consciousness, that they're not even aware that these things are happening. Is it being concealed somehow? Is it being sort of swept under for whatever reasons that we're not aware, political or otherwise? I'm not sure. But yes, nurses, many of them don't know it's actually happening. I wouldn't say nursing is on unstable grounds, but it has the potential of becoming so if they did speak up, given the relationship with doctors, right? I mean, it's physician-nurse, you know, it's a sub-collegial relationship. There is a power difference there. You know, nurses are, they carry out orders. They respond to institutional needs and institutional interests without, I would say, without political questioning, or without, you know, the critical thinking that, you know, we as this group would want them to have. But so they wouldn't even go as far as, even if they were aware that ACT is being administered as much as it is now, to even criticize it. So they don't know the quote-unquote side effects of ACT and the damage that it does to people, like Bonnie read to us.
Also, I think what keeps professionals from speaking out is that they are also targeted by psychiatry. So, you know, for example, myself as a trans person, I am forced in many ways to be in relationship with psychiatry. And so then therefore to question a psychiatric treatment, you know, puts me at risk, puts my access to healthcare at risk. And also, I think it puts, it can, you know, to speak out against such a powerful institution, you know, one of the things about the power of psychiatry is that if you invent illnesses and you can't, you know, demonstrate scientifically that they exist in the body, so by inventing illness, I mean, of course, the voting that happens to you know, bring a so-called psychiatric illness into existence, which then gets recorded in the Diagnostic and Statistical Manual. If that's an invention, and if your resistance against psychiatry or being psychiatrized is deemed to make you even more, you know, ill, because you don't fully understand what's happening to you, then, you know, resistance in general against a psychiatric treatment or a psychiatric intervention puts people at risk of not being seen as legitimately belonging to a profession, or as having the awareness or the insight, or even perhaps as, you know, being afflicted by a mental illness themselves. So the stakes are very high.
Any decade, and I've been watching this since the 50s, so that's a long time. Every decade I've ever seen, not the 50s, but starting with the 60s, people thought it was abolished years ago, and including many professionals. And I think that one of the things behind that is it's dangerous to question, and it's easier to believe it was abolished, right? And so people would rather think, and those who don't think it was abolished, it's easier to believe the line, it is new, it is modified, it is improved, and everything probably really is fine now. It probably really is true that everyone just got scared by One Flew Over the Cuckoo's Nest and the image there, the thing Shorter puts forward. And so I think there's a degree to which it's easy to slip into bad faith around this because it's threatening to actually look at it and to question it. And yet, that's our role. That's our role. I mean, nobody who is caring for people who are in trouble and knows this threatens them should be allowing themselves to slip into bad faith. And yet people do, and they don't just do it in the hospital. In the hospital, the threat is enormous. Outside the hospital, the threat is a great deal less, but people still feel it. So I know I speak out against it, and I know one of the consequences of that is that everyone will try to stop every scholarly conference I put on, that I will be critiqued in the newspaper as a nut-brain Californian when I'm neither nut-brain nor Californian. So I know that these things are going to come up. And so one has to accept that in order to critique these things. And that's not something most people are willing to do, and yet if enough of us do it, the threat and the consequences start going down, very, very greatly, if we could get that voice. That said, I would like to take us to another question, if I might, and that's that what are the people that you guys see as in most jeopardy of being given ACT, or if not of most jeopardy, in a special kind of jeopardy? So let me enlarge it to both of those groups. And, you know, let's not just, let's not get into a conversation about it. Let's just assume anyone sees of, you know, just call it out so that we can get a kind of picture.
People who are really suffering and without support. I see people in the hospital all the time that are in sort of modes of confusion and not really sure what's happening, and then informed consent can't happen. There aren't people in their lives to advocate for them, and then they end up sort of being forced into these so-called treatments really against their will without knowing what's happening.
Being at risk for this kind of a psychiatric intervention requires a few different things. Primarily that kind of vulnerability, lack of information, and within hospitals, when you're right in that kind of critical moment of deciding, often you're in the hospital, the videos that are shown to promote the benefits of electroshock therapy are in fact funded by the very same companies that make the machines. So it's both vulnerability and lack of information in a very profound institutional way.
Certainly people in emotional pain who get caught in the net of psychiatry, particularly women, pregnant women. I've seen some literature on pregnant women being given ECT, which is quite disconcerting. Children and the elderly.
And Simon, there's statistics on all of those groups, and you know, we don't need statistics to know that the vulnerable are at most danger. You know, the image of who gets electroshock is very, very clear, and it's, believe it or not, middle-class white women, overwhelmingly middle-class white women. And you know, we're going to have to, we need to probe more to see why that's the case, but that's where the big jeopardy lies. And young women and very old women are the two big categories within that. And again, that needs probing. Okay, I want to get to, you know, the difficult question, because we want to see progress on that, and progress means banning electroshock. Let's be clear, it's not better or improved, it's banning electroshock. And my sense is that there has been a huge and very successful movement in many ways by survivors of electroshock and their advocates. But there has not been enough professionals speaking out, and until we get more professionals speaking out, it is very hard to get this treatment banned. How do you see us shifting our various professions so that people do speak out?
Something like the Healthcare Professionals Speakers Bureau that we've started is the place sort of where we start in creating communities. I think that it becomes really terrifying to speak out as an individual, but it becomes a lot more comforting to speak out as a group of individuals, or to know that you have support around you. So I think that we really need to definitely start creating communities like this amongst professionals, where we can sit and dialogue about sort of what we've seen and strategize for ways to support each other in being advocates within and outside of the system.
This point about we can't just make ECT better or more effective. The reason for that, in my opinion, is that it's never been shown to be something that was useful to people. You know, there's certainly testimony by a few, by some survivors that say that it was helpful to them in the short term. There's never been any long-term studies of the impact of electroshock therapy, and in fact, there's never been any, you know, definitive evidence to say like why it was brought about in the first place. In fact, the man that invented it immediately after said, "Oh no, I've done something terrible, and we can't use this on human beings." It was used on pigs originally.
It's interesting, Ambrose, because he actually used the term, "This should be abolished."
This should be abolished, indeed. You know, yeah. So I think concretely, in order to change the profession, there has to be, you know, efforts on the part of professionals to really get at what is this treatment. You know, back when we were talking about why people don't speak out, I think something we missed is that as professionals, when we encounter people who are really struggling, really have, you know, terrible problems in living that are, you know, severe and pronounced, it often happens, this is my opinion, that that people get afraid, that we get afraid as professionals. We don't know what the answer is, we don't know what to do, we don't know how to help this person, and so it's very, it's kind of this wonderful solution, like send them to the hospital. We don't know what happens, or we don't really need to be responsible past that. Our code of ethics, our associations, the law, all give us permission to kind of like pass the buck on individuals where we feel overwhelmed. So I think the first thing about not feeling overwhelmed is to get educated, to really read the literature, to really get at some stories, some studies, some scientific studies, to really break down this the myths that this treatment is based on sound science, and even that the diagnoses in the DSM are based on sound science. I think breaking down those things is our best way forward.
We have really concrete, clear research in psychology that shows like what is the mechanism of change when people engage in sort of like a therapeutic relationship, and it's the relationship between two people.
Yes.
That is the change, not the interventions or so-called or techniques so-called. It's two people sitting together and supporting one another. So if we shift the frame in which we think about these professions, it's just we're sitting and supporting people in their times of need. And then that makes it less scary. We don't have to figure out what's wrong, quote unquote, or fix it, quote unquote. We just have to support one another in these moments. And I think then that gives it a lot more of a humane sort of basis where we're going from. And the research really supports that. And so
Absolutely.
I think that's the type of research that we really need to be putting on the forefront.
I kind of agree and don't agree. So let me be clear about it. I think we have cores of good research, and I think we have cores of alternatives that are good. We've had them since the days of Rogers. We've had them since the huge rise of the humanistic therapies in the 70s. We have them, right? So it's not that we need to develop them, and it's not that we need to do more good research, but all sorts of good research gets done and gets buried. We need to take on this profession. We need to take on this profession that's doing this to people and saying, we stand against you in this because you are harming people. And so we like to think if we just generate more alternatives, everything's going to be fine. And my sense is we've done that. What we haven't done is stand up and be counted, and I think we need to stand up and be counted.
You've alluded to this earlier, Bonnie, by suggesting that it's very hard in the hospital, and it really is. I mean, me as a nurse having one foot at the bedside and another in the nursing academy, shifting this at the bedside is impossible. I've been there and I've tried to do that. And as I said earlier, the small little pockets of discussions that we have at the bedside render, ECT is still happening, or they still do that, or there is this high level of ignorance, if you will, let alone knowledge, criticism, resistance, change. It's very, very difficult to shift at the bedside. Nurses are caught up in the grind of the institution. They set foot in, they do their 12-hour work, and they set foot out. There's no room for an alternate consciousness there. I think targeting it at the production of the nurses, which is the academy, is one way to do it. I think I teach in the undergraduate nursing program, so in my teachings I bring attention to the problems of ECT and psychiatry in general as well.
Absolutely. Let our colleagues know, whether it be in nursing or in psychology or whatever, that if you get in trouble by critiquing this profession, we will stand there with you. We will stand there if it means going to a court of law to sue them for trying to take your job away, that you will not be alone facing this onslaught. Because I think people who are scared for their jobs, there's less they're willing to try if they think they're going to be backed. I think that's different. And so I think we need to commit ourselves to backing people in that situation.
It really, psychiatry is an institution that's very, very much integrated within the structure of the state and governments and popular culture and media and so on. It's very entrenched, and so organizing directly against psychiatry requires us to be in community with each other, helping each other, get access to the information, and really, backing each other up, as you said, Bonnie, but in a way of like tying all of these little pieces together. You know, yes, starting when people are learning. You know, ultimately, this is I think a struggle that requires so much persistence and longevity. This isn't something that we can get informed about and get outraged about and you know, talk to our boss about. Like, it's something that requires way more creativity and strategies. At the same time, too, I think as professionals, there's another piece that we can do, which is to support people who have been the victims of ECT and who are trying to speak out. And I think putting some of our clout, you know, into being in solidarity with those speakers, those who are speaking out or taking action is very, very crucial to building this community in a more comprehensive, you know, solid, grounded way.
This is doable. This is doable. Psychiatry has specialized in horrific treatments, let's be clear, and we have, as caring people, gotten rid of them in the past. We got rid of lobotomies when they actually said it was safe and effective. Can you imagine it? Cutting out people's brains, cutting it safe and effective. They declared it safe and effective, and we got rid of it. We got rid of the rest cure. We got rid of, you know, insulin therapy. One by one, we now, unfortunately, psychiatry replaces one brain damaging treatment with another, but we have gotten rid of them. We can get rid of this. So I think we need to know that. We need to know this is doable. That said, we want to leave you with, we talked about a lot of misinformation out there. We'd like to leave you with some real information. What you're going to see scrolling down your screen at the end of the video is a list of the real effects of electroshock.